be, and participate as we finalize with today's session. Yeah, so we're on top of the hour now. Allow me to welcome each and every one of you officially to this session, the 31st of December 2025. This is the final day for our webinars this year, and so we are honored to host you today. In addition to that, it is worthy to note that we are now just counting hours and minutes as we end this year. So after this, we will enter the next year, which is 2026. We are very honored and we are very glad to have you in this space today. My name is George, and I'm honored to be your moderator today. And our presenter is a professional, very experienced in the field of medical laboratory practice. Is a professional who has actually done exemplary presentations in our previous sessions. And today is also another exciting topic about thyroid function tests in children, in neonates. And it focuses on hypothyroidism in neonates. So our presenter will just tackle this in details. And allow me to introduce our presenter for today, who is Mr. Agri Marube Nyaboga. So, Mr. Agri, wherever you are, if you can hear me, kindly confirm so that we can proceed. Mr. Nyamboga. Are you able to hear me? When you confirm, then the rest can also hear me clearly. Mr. Agri, would you please confirm? You can unmute and confirm.
Yes, George, I can hear you clearly.
Thank you very much for that. So at this point, allow me to hand over this session to you so that you can start your presentation and proceed. Over to you.
Thanks a lot, George, for that kind introduction. And today I'm honored to do the last presentation this year, 2025. And we are going to learn about neonatal hypothyroidism. And in this, we are going to look at clinical significance of neonatal screening of hypothyroidism. This is a very important topic, and this is a type of screening that more often is overlooked. And we find that in third world countries like Kenya, we are left behind, but in certain standards, especially the hospitals that are attaining certain standards, it becomes a mandatory test, especially for neonates. And we have worked in facilities that also usually ensure that neonates are screened for this. Now, neonatal hypothyroidism is a very important medical screening that will enable the medical fraternity to ascertain that the development of a newborn is well assured to be in the right course as the baby is born. So as an overview, the webinar will focus on thyroid function in regulation of congenital hypothyroidism, which is a thyroid hormone. Usually thyroid hormone such as T4 is usually deficient during birth. Further critical examination on the key aspects of the condition of neonatal hypothyroidism is going to be examined, and we're going to look at the role of TSH and thyroxine, that is FT4 or T4, in diagnosis and management of neonatal hypothyroidism. We're going to look at the evaluation of the physiology of hypothalamic pituitary thyroid axis in neonates, as well as the pathophysiology of neonatal hypothyroidism is going to be examined. So what is neonatal hypothyroidism? So in a nutshell, it is a condition in which the thyroid gland does not produce enough thyroid hormones. And this hormone is usually thyroxine to meet the body's needs. About 1 in 4,000 newborns are usually born with hypothyroidism globally. 1 in 4,000. You see, this ratio is significant. 1 in 4,000. So this brings a big issue, especially on facilities that don't usually recommend or they have forgotten such cases, and they don't they are not emphasizing on screening of neonatal hypothyroidism, and they are left behind. And this leads to a country facing a lot of problems, especially in handling the thyroid issues and the growth of newborns, especially in their early stages and development later in life. It's quite significant. So if we can calculate the newborns who are born, especially in a year, or even if we look at the population of newborns in every year, and we calculate to get the ratio of 1 in 4,000, we'll get significant numbers that will actually put pressure on healthcare facilities and put pressure on families and many other aspects of the economic state of a country. So this is key and significant. Now, as we look at the neonatal hypothyroidism, we are also going to look at the anatomy of the thyroid gland, the pathophysiology of this condition, and other aspects that involves how the thyroid relates to other organs like hypothalamus and pituitary gland. So enough with the introduction. Now we are going to look at the nitty-gritties of neonatal hypothyroidism. As we consider the thyroid, which is usually a small gland, which is butterfly-shaped, and it's located in front of the neck. It uses iodine from food that we eat to make thyroid hormone, also called thyroxine. That is T4. Of course, we know that there are two thyroid hormones, usually T4, and which is thyroxine, and iodothyronine, which is T3. But we're going to focus on T4, and there are reasons as to why we focus on T4 or thyroxine. Thyroid hormone plays a vital role in normal growth and development. If a thyroid gland does not develop properly, it will not produce enough T4, that is thyroxine, for normal body growth and brain development. So we see thyroxine playing a key role in metabolism, gearing up these metabolic processes for normal body growth and normal brain development. And these are key in neonates. Now, we're going to look at thyroid function regulation. Like most of other glands, thyroid makes hormones in the body just like any other, that's just like other glands that produce hormones. The thyroid is under control of the pituitary gland or the master gland. The master gland is located at the base of the brain. We are going to see how the master gland, that's the thyroid, that's the pituitary gland, how the pituitary gland influences the thyroid in order for it to function properly. And we are going to look at also the relationship between also the pituitary gland and the hypothalamus, and the pituitary gland in relations to the thyroid gland, and also the thyroid gland in relations to the hypothalamus. Look at that axis and how it plays a role in the metabolism of the hormones that are in picture. If the amount of thyroxine in the body is too low, the pituitary senses it and releases a hormone that is thyroid stimulating hormone. We're going to look at how they relate to each other, mostly in the negative feedback. So if the thyroid gland is, the thyroid hormone, that is T4, is too low, it will trigger the release of thyroid stimulating hormone, that is TSH. And this TSH is produced in larger quantities so that it can enable or more production of thyroxine so that it can normalize. That is a negative feedback mechanism. Then we're going to look at the key features and the symptoms of neonatal hypothyroidism, which in key sense, sometimes without experienced clinicians usually miss out. And this, if we have clinicians on board, especially in our presentation, it's usually, it takes some experience for us to be able to diagnose the neonatal hypothyroidism. This is very important in consideration that we have laboratories which can provide key diagnostic measures, especially in testing, for us to be able to diagnose or to clearly be able to identify this condition before it destroys the baby's development. So the key symptoms are physical appearance, usually puffy face with a large tongue. That's called, a large tongue is referred to as microglossia. There are also swollen eyelids, cool pale skin, large soft spots, anterior fontanelle, anterior fontanelle, umbilical hernia, protruding belly button. So the protruding belly button is also key in diagnostic, as one of the diagnostic features. There are also behavioral changes for newborns. There is excessive sleepiness, lethargy, and decreased activity. There is what we call floppy, poor muscle tone, and hoarse or weak cry. These ones can be identified. So these symptoms are usually overt, but if there is, if we don't have a pediatrician who handles these babies, they can be missed out, because unless other clinicians are trained to do the same, to do a proper diagnosis. So there is also issues with feeding and digestion. There is poor feeding in general and difficult swallowing. Babies, poor feeding means that babies cannot breastfeed. Sorry. There is a poor response to breastfeeding, and it becomes a very big issue. And this can be attributed to difficult swallowing. There is low weight gain. You've seen, I've seen conditions, especially for babies, condition regarded as FTT, that's failure to thrive. And patients, especially babies, being referred to tests that are not moving in tandem with such diagnosis. Maybe clinicians are trying to advise even the mother on what to eat, to take tests to be done, and they are failing to hit the mark. And this is a gap that I've usually seen in some healthcare setting facilities. But we can share notes with the clinician so that we can help out in diagnosis. And because we are endowed with knowledge, we can also use this knowledge to help. It cannot be only in the healthcare setting. We have friends, we have families that we can chip in to help to seek for diagnosis, and also which leads to proper response in treatment. There is constipation, there is infrequent stools. Skin color is also in picture, whereby we have prolonged jaundice, yellow skin, and eyes. You see, more often this can be attributed to issues with the liver, but at times it's not mandatory that it's a liver issue. Yeah, it can be a neonatal hypothyroidism. There is also dry skin, and these conditions, even if we look at these ratios, this ratio of 1 to 4,000 is not a big ratio. So these conditions are common. They are common. There is also slow growth, as I've stated. There is what we call failure to thrive. Failure to thrive will be evidenced by slow growth, short stature, and short limbs. What can cause the thyroid gland not to work properly? It's a question that we need to ask ourselves. The most common cause will be improper growth of the gland. During early pregnancy, development of thyroid gland begins to form at the base of the brain and then moves to the lower neck where it finishes growing. Sometimes the process is interrupted, leaving only a small piece of thyroid, which can be abnormal, which can be in abnormal location. Some babies will have no thyroid gland at all. The thyroid gland will not be where it should be. When scans are done, it will not be found. Maybe it has not moved to the place where it should be stationed. It still remains at the back of the brain, the base of the brain, and maybe it can undergo atrophy also. So less common causes of hypothyroidism is, for instance, include lack of stimulation of the pituitary gland or inability of the thyroid glands to properly make the thyroid hormone. All these causes can result to lack of thyroid hormone, which the baby needs. They are permanent conditions which the baby will not grow out of. Consider that, how debilitating the condition can be, and how it can adversely affect the baby's development. Medicines the mother took during pregnancy can lead to the thyroid gland not to function properly. There is also lack of iodine in the mother's diet during pregnancy. Antibodies made by the mother's body to block the baby's thyroid function. And this is whereby certain legislations that enforce the spiking of food and food products with iodine, even the food additives are spiked with iodine, like now the table salt it's mandatory for manufacturing companies for table salt to iodize it, to add iodine into it for it to hit the market. Without addition of iodine, KEBS cannot allow salts to be available on the shelves. So these are legislation that is very key in prevention of such conditions. Both neonates and adults issues pertaining to the thyroid. In neonatal hypothyroidism, commonly is missed out. I've stated situations where it can easily be missed out due to maybe lack of professional experience in diagnosis of this, examination and diagnosis of this. And also, you see, even the clinical picture can guide for the clinicians to request for tests to either rule out or make a diagnosis on such conditions. Sometimes newborns with congenital hypothyroidism show few or no symptoms at birth. It's often described as good babies who sleep and cry less. As I've stated earlier, these conditions, one of the clinical picture is that these babies are poor feeders. One of them, poor feeders, breastfeeding is very poor. And this one cannot clearly alert a clinician if no proper experience or no proper expertise involved. They cry less. They are good babies in general. Yes, good babies don't cry a lot. Good babies don't, okay, they sleep well. Yes, but now when this is becoming too much, this will bring us into question. This will bring us into question. What are we supposed to do? In addition to other symptoms like puffy face, yes, swollen eyelids, and other symptoms that I've stated earlier in earlier slides. If such overt symptoms are not there, there can be few other symptoms, but others might be missing, which can lead us to have a clear clinical diagnostic picture. This means that this underscores the mandatoriness of the newborn screening, the neonate screening for the neonatal hypothyroidism testing. We usually do T4 and TSH. We'll look at thyroid pituitary axis. The TSH stimulates the normal thyroid gland to produce more T4. When the thyroid gland produces enough T4 for the body's need, there's no extra stimulation. The stimulation stops because the enough T4 has been reached, and TSH levels drop to the usual low levels. This is usually key. It's for us to understand this physiology and how things work, so that when the results we release our results, we are able to be able to interrogate what we are producing. And further interrogation will lead us to proper calibration of our equipment or proper communication or proper interrogation of our results to enable us to underline key issues. In most hypothyroid babies, the thyroid gland has not developed properly and cannot produce enough T4. Consequently, the pituitary works very hard to stimulate the thyroid gland by producing high levels of TSH as a result. Now, these babies have, usually, as a result, these babies have low T4 and high TSH level. So in such a cases, we find that there is an imbalance in this case, whereby the thyroid works very hard to stimulate the thyroid gland to produce high levels of TSH. As a result, these babies have low T4. and a high TSH levels. Hypothalamic pituitary thyroid axis is the next issue that we're going to look at, especially neonate. It's a crucial system for growth and brain development. Maturing in utero, but undergoing significant postnatal shifts with massive TSH surge after birth, leading to an increased T4/T3. And this is usually a normal response. But later on, when T4 surges and T4 remains low, it shows that there is an issue that needs to be addressed. This shows that we are getting close to handling the issue or reaching at a diagnosis, or we've reached already at a diagnosis. It is in this thyroid hypothalamic pituitary thyroid axis, we'll find that this axis is regulated, or is a regulatory system that is controlled by negative feedback. Usually, T3/T4 stop thyroid release hormone /TSH, but remain immature in premise, requiring careful monitoring due to potential disruption from prematurity, illness, or maternal Graves' disease, impacting diagnosis and treatment. So there are issues that can also contribute to this, especially we find that that these hormones don't clearly reflect the clinical diagnosis that was released by the clinician, or that was gathered by the clinician. However, it's key when things very important to note, or key to note, that some of these results might not give a clear picture on what is happening, and this one can be in relations to other glands and how they are functioning in relations to the thyroid gland, because we have the thyroid gland under the control of the hypothalamus and also the pituitary gland. But more often, when we have neonatal hypothyroidism, there is usually high TSH, which does not give results. TSH is usually meant to raise T4 T3 to normalize. After normalization, the TSH will go down. So we usually have low TSH, normal TSH, according to the reference ranges, with normal T4 and T3. But when we find that there is no balance in this, the hormones that we, as we expect them to behave, there is an issue with the thyroid in the neonate. Hypothalamus usually releases thyrotropin release hormone, that is TRH. The pituitary gland stimulates it to release thyroid stimulating hormone. So in this matter, we realize that the pituitary gland will release the TSH, but the hypothalamus will play a role in releasing of thyrotropin release hormone, that is TRH. So TRH will trigger the thyroid gland to release the TSH. So this cascade will lead to TSH being released to the thyroid gland to stimulate more production of T4. T4 usually is converted to triiodothyronine by the removal of, by deiodinization. That means iodine is removed. One iodine molecule is removed, and there remains 3 iodine molecules. And when it remains 3 iodine molecules, we have tridothyronine. Negative feedback mechanism is whereby high T3/T4 levels signal the hypothalamus and the pituitary gland to reduce TRH/TSH. Commonly, what we understand, not we understand, some laboratory professionals or even clinicians, commonly what is immediately understood is that high T3/TSH levels lead to suppression of TSH in order to create a balance. But we need to understand that thyrotropin release hormone comes into picture also in this matter. So we'll have to ask ourselves, how is the hypothalamus responding? Could there be a need of us doing assessing the function of the hypothalamus by running the TRH test? Is there any need? Sometimes there can be need. In rare cases, especially when these things are not clear, and there is a confusion because there are confusing situations that might arise in complicated things. Medicine has so many complicated things. But in rare cases, we'll have to go to assess the hypothalamus. The hypothalamic pituitary thyroid axis in neonates, the axis components and functions. As I've stated earlier, is that the abnormality of the hypothalamus of the pituitary will definitely affect the thyroid function. And that is where there are few cases that we have to go and test the pituitary function or the hypothalamus function. And this is where specialists are needed, maybe in order to go that far, maybe when conditions necessitate, when diagnosis becomes obscure, and there needs to be more assessment. The hypothalamus releases thyrotropin hormone, that's TRH. TRH, as mentioned in the previous slide. The pituitary gland stimulates it to release thyroid stimulating hormone. The thyroid gland is stimulated by the TSH to produce thyroxine. And you see, as more thyroxine is released, it means that there will be also more and adequate tridothyronine, that's T3. The negative feedback goes this way, that high T3/T4 levels signal hypothalamus and the pituitary to reduce TRH and TSH to maintain the balance. I've repeated this for emphasis. Challenges in neonatal thyroid function. As stated in other slides before, there is prematurity, and we have immature axis. Immature axis means that immaturity in the hypothalamus and immaturity in the pituitary gland. And this immaturity can result also from poor thyroid maturity. Because if there is poor brain development, brain has a number of components. And these components can include the hypothalamus and the pituitary gland. So it can be a vicious cycle, one gland affecting the other. So this is where we are talking about the immature axis. Maternal antibodies can cause transient hyper or hypothyroidism. We have also fetal dependence. Fetal relies on maternal hormones until fetal thyroid starts to produce its own hormones in the second trimester. So what about if there is an issue on the mother. The mother has thyroid issues, and this leads to imbalance early in fetal life. What happens in such a case is this now leads to now neonatal hypothyroidism. We have it's a continuation of challenges in neonatal thyroid function. We have also postnatal surge. A sharp rise in TSH occurs within hours of birth due to placental separation and thermal stress, boosting T4 stroke T4, T3. So in maturity, especially when we have preterm babies and sick infants, we have immature HPT axis. The hypothalamus, pituitary, and thyroid axis is immature, as I've mentioned, making them prone to hypothyroidism, even with normal initial screening. Maternal influence, in addition to what I had stated earlier about the maternal issues, we have maternal thyroid conditions like Graves' disease can also contribute to this issue. This can affect the neonate via antibody transfer. So autoimmunity is another angle that we need to look at it. So this one can also lead to us, especially to be able to handle the mother's issue and go in full swing to handle the mother's thyroid issue if it was not diagnosed earlier, and also to handle the baby's issue. So it can lead to spiral to other and open up ways to diagnose of even the mother. When to suspect hypothyroidism in screening test results, we have to look at key issues now in reference ranges. When you have TSH levels above lab cutoff, e.g., less than 20 to 40 MIU per liter, it can trigger further. This one will should trigger us to further investigations with confirmatory tests, serum test results, TSH and T4, free T4. So some labs will, some clinicians will request for TSH. When TSH is elevated, then it will prompt them to also request for T4. Some clinicians will request for both T4 and TSH. So immediate treatment after diagnosis, especially with high levels of TSH, e.g. greater than 40 MIU per liter, treatment often starts immediately before full confirmation to protect the brain, to ensure that the brain is developing well. So the key issue here is brain development, and the brain has to be protected at all costs, and this will trigger an onset of or the genesis of treatment. We are going to look at a physiological search of TSH, as we all understand that TSH plays a very important role in diagnosis of thyroid issues and also the T4. When physiological abnormalities of TSH can result from illness, we are going to look at that. A physiological surge in TSH occurs within the first 30 minutes of life and appears to be related to stress of delivery and exposure to the cold temperature of extrauterine environment. So the birth itself, the process of birth can trigger this. And also serum TSH peaks at levels of as much as 70 MIU per liter within the first 24 hours of life, then rapidly drops to less than 10 MIU per liter within the first 3 days of life. Beyond the neonatal period, healthy serum levels of TSH are less than 6 MIU per liter. And in this, with this knowledge, we now understand when this test should be requested for. And for us to optimize the diagnosis, because when we miss this timelines, especially in drawing the sample, we sometimes we can get equivocal results. And what we want to eliminate here is doubt. So to eliminate doubt, it's good for us to look at these days. 3 to 5 days of life, 3 to 6 days of life, 3 to 7 days of life. But sometimes it can go up to the 14th day. But it's good for us to be to pinpoint or to look at the best timelines. That is 3 days to 6 days of life for the sample to be drawn, or at least after 24 hours. So those are the reference timelines that we should look at. When we look at serum TSH levels, they are usually elevated in primary hypothyroidism or compensated hypothyroidism, and should be low within the reference range in cases of pituitary TSH deficiency or hypothalamic TRH deficiency etiologies. Now let's look at let's keenly look at the thyroxine. Thyroxine can be present in both free state and bound state. And we have thyroid binding globulin or thyroxine binding globulin, which is TBH, which usually binds thyroxine. When it binds to thyroxine, it's called bound thyroxine state. But when it's free, not bound to TBG, it is called free. Now, the total T4 assays measure T4 in both states and are useful not only in establishing the diagnosis of primary hypothyroidism, but also in assessing response to treatment. The key T4 characteristics in neonatal hypothyroidism are primary hypothyroidism. In primary hypothyroidism, we have low T4, both total and free, and high TSH. This is a key consideration we should look at, especially in primary hypothyroidism. Low T4, both bound and free, and high TSH. In subclinical hypothyroidism, there is a normal T4, both total and free, both elevated. TSH, sorry, but elevated TSH. So elevated TSH will lead to normal. And this one brings usually confusion. And this is what we call subclinical hypothyroidism. And usually brings a confusion in testing and a clear diagnosis. We also have central hypothyroidism, where we have low T4 stroke FT4 with low normal TSH. So both the thyroid hormone are low and thyroid stimulating hormone are low. This is what we call a central hypothyroidism. Why T4 are important? Thyroxine is important because it helps in in brain development. Adequate T4 is vital for normal growth and also normal brain development. in few years, the first few years of life. So we see thyroxine is very important here. And we diagnose abnormalities in especially in the thyroid gland when we have low thyroxine. And this one is a confirmatory test for neonatal hypothyroidism, but when TSH is high. Monitoring, FT4 levels are closely monitored during treatment to ensure that there is adequate replacement. So at the genesis of treatment, then after the diagnosis, the clinician needs to give a routine return to the clinic for assessment and monitoring of the thyroid gland. And the measurement of FT4 is very key to see whether there should be a change in the course of treatment or not. Now, what about the prognosis? How is the outlook of treatment of neonatal hypothyroidism? Getting undiagnosed, that is early diagnosis, leads to a good outcome. So for us to have a good prognosis, in any other condition, there has to be early detection. Early detection is key. Newborns diagnosed and treated in the first month usually have normal intelligence. Yes, we talked about brain development and also physical development. So there are issues that come with the intelligence and abnormal brain development, and these issues are debilitating and later in life, and it can be due to a missed diagnosis. Misdiagnosis will affect the rest of the life of this individual. So untreated mild hypothyroidism can lead to severe intellectual disability and growth problems. The nervous system goes through important development during the first few months after birth. Lack of thyroid hormone can cause damage and cannot be reversed. This is what we need to understand. In conclusion, this condition, if untreated soon after birth, severe congenital hypothyroidism can lead to growth failure and permanent intellectual disability. Infants born with congenital hypothyroidism or neonatal hypothyroidism may be asymptomatic or may display mild symptoms that go unrecognized as a problem. Significant deficiencies may cause excessive sleeping, reduced interest in nursing, poor muscle tone, low or hoarse cry, infrequent bowel movement, significant jaundice, and low body temperature. So we can see how why our healthcare facilities or our healthcare standards in this country should adopt such standards. Maybe even the lab fraternity should be included in key issues or decision-making issues, especially especially in setting policies. And I'm happy that some healthcare facilities have adopted this. And now you find that every newborn is screened for neonatal hypothyroidism. I'm happy of such a facilities because it's very important. And when a patient asks you, now because you've attended this CME, now the mother to this baby now is your patient. maybe some I've handled so many cases, and I've sat down with the mothers or the parents to explain such issues. Some people can brush off and say, this is not important. No, the baby is crying too much. Let's leave it alone. What about it was a chance in diagnosing the neonatal hypothyroidism, and it's missed out. So this is a good ratio. 1 to 4,000 is a good ratio for us to consider screening all the neonates. This is my the end of my presentation. Back to you, Bwana George, for moderation. I really appreciate your audience. Thank you.
This is wonderful, Mr. Agri. Today's session is an eye-opening one, and I would wish that even after this session, those who participated can share the link to our colleagues so that they can just have an ear to the presentation. This webinar is live streamed on our YouTube channel, and so for those who'd like to make some reviews a day after today, next year going forward, you can just search by typing the name of the title of this webinar, or rather you can also subscribe on our YouTube channel at Lab Medicine Kenya. So that's our YouTube handle at Lab Medicine Kenya. So thank you very much, everyone, for being here, and also engaging yourself to this presentation from start up to this moment. I'd like to appreciate and acknowledge the presence of Abraham Lomulel from Turkana LCRH Lab. Thank you very much for that, Mr. Abraham. You've asked about notes. Please check our YouTube handle. You'll find all our presentations there. It's better to listen through the presentation, and if it's the slides, then you can also view them as they're being played on YouTube. I think that's the best decision ever that we made this year as we started offering CPD sessions. So make good use of that. We are glad that you made it, and also I acknowledge the appreciation of Kegode, nice presentation. Morris sharing, say that it's very educative, as well as David Kaito. So there's a question here. Grace Mokwa is asking some questions here. So I'll just read it. Grace Mokwa is from Nakuru. Thank you very much for presenting us from the region. So can babies before feeding be screened for TFTs? And attached to that, what is the main cause for hypothyroidism and how can it be prevented in neonates? What do you agree?
Yes, thanks a lot for that question. It's a good question. And now, babies who present with symptoms of neonatal hypothyroidism, of course, they should be screened. Maybe interventions that come later can help a little bit in making especially arresting the progress of brain damage, and also physical development of the child. But now the damage is already caused, and now what we are trying to arrest is further damage. So it's very important for us because to reduce that anxiety and also spending a lot of money to look for treatment where we cannot get a resolve. Is for us to do thyroid assessment. So yes, definitely yes, is that we should go for thyroid testing when we see overt symptoms like this, and they were missed, especially in the neonatal period. So that's very important. The second question is about, sorry, if you can repeat the second question, sorry, George.
Second question,
Yes.
Grace is asking about the causes of hypothyroidism and how they can be prevented in neonates. So the
Oh
causes of
yes, causes.
hypothyroidism in neonates can
Mm.
be prevented.
Yes, definitely. That's a good question. The causes of neonatal hypothyroidism and how they can be prevented. I've talked about issues dealing with the thyroid, especially autoimmune causes. Autoimmune causes, especially in toxicosis, the thyroid issues that where we have autoimmune conditions, and the antibodies are passed on to the neonates. Now, when we realize that the mother has thyroid issues, and every mother who has thyroid issues, and this mother plans to get a baby, the thyroid hormones should be closely monitored and treatment given. If not, this mother will impact the baby. And this is whereby we get congenital hypothyroidism. That's neonatal hypothyroidism. Is one of the major causes. So any mother who has thyroid issues, these thyroid issues should be monitored and treatment given, and continuous monitoring until birth. And also, even at birth, the mother should be ready for this baby to be tested at the correct reference time after birth. Another issue is that the prescriptions usually given to mothers during pregnancy are also important. That's why it's key. The treatment is usually key for consideration by experts, especially when a clinician is not sure on what medication to give an expectant, expecting mothers. It's better for the clinician to refer to experts such as gynecologists. And after the baby is born, where resources allow, especially the expertise allow, facility where if the enough expertise, especially presence of gynecologists, presence of pediatricians, the baby is usually handed to pediatrician who knows on what to do with the baby, and having the clinical history of the mother. Yes, having understood that the mother has thyroid issues. Definitely, this one, even if we don't have the hospital does not have a regulation that enforces screening of babies, this expert will know that this baby should be screened for neonatal hypothyroidism. So this is another way that we can prevent neonatal hypothyroidism and consequences that follow later. So prescriptions are key. That expectant mothers should not be prescribed medications anyhowly. And there is a gap in Kenya, and that's where training is needed. Training is needed for us to prevent neonatal hypothyroidism. Training for lab fraternity, and this is what we are doing. Like now, we can advise You can advise the mothers, the parents, you can advise them that this screening is very important. Let's go for it. We can advise, we can share notes with clinicians. Yes. So it's important. Training is very important both for clinicians and also the laboratory personnel. Thank you.
It is very good that thank you very much for that extensive answer to the questions that was asked with Grace. So thank you very much for that. I can see Mr. Anthony. Mr. Anthony seems to have some wonderful input and a question as well and some concerns. I think, Anthony, if you are around, I'll just give you time to just speak. So just prepare yourself. So before I give you the chance, let me allow our presenter to give an answer to this question. Siroma Juma is asking, does it mean that the diet of the mother on iodine intake can affect thyroid of the babies? Does it mean that the diet of the mother on iodine intake can affect thyroid of the babies? I don't know if you can get the question.
Thank you, George. I can get that clearly. Yes, definitely. It's a good question. Definitely, it can affect. That's why the mothers are usually advised on balanced diet. Definitely, yes, it can affect. Can affect.
Thank you very much for that. Amos Kibiwat is asking about drugs that can interfere with thyroid gland development. Do you know of some drugs that can interfere with the thyroid gland development in expectant women?
I might not knowing about drugs. Maybe. Okay. I cannot be able to know about drugs because of my limitation in practice. Thank you. Maybe with the references, I'll be able to know the consultation. Maybe you can do consultation with clinicians. You can be able to help.
I think that is for example, it's more consultations and also deep reading and studies, so that you can ascertain that actually this particular drug interfere with the thyroid gland development. Oh, Mr. Randall Anthony, are you there? You can please unmute and just speak about the concern, the question that you might have. Okay, over to you, Mr. Anthony.
Thank you, friends. Thank you, colleagues. This is a very interesting a topic I really followed keenly, and I must say thank you to the presenter. Now, this is related to this, but also touches on the wider role of medical lab professionals in the health management of and care of patients. Now, I've asked there just to what my question directly is that often what to test and when you get the results, how to interpret it have a bearing on how the care is provided. Now, that interface usually require both teams to have some common understanding. And I'm asking this because my background is training. Do you think there can be something you can think in a group and maybe somebody can make a comment? Do you think that we need to have some clinical skills in our training in order to fit in that space very well? I think this is something that I really just want to get the presenter's opinion and any other person as to advise me as a person who is involved in training. Thank you, and back to you.
Yes, thank you very much, Mr. Anthony, for that. Mr. Agri, any input?
Yes, I understand the concern of Andrew, and the question is: do we need to have clinical skills? Definitely, there is. Okay. Such information is usually given to us, especially during our training. We understand these things. However, it does not go far to the clinical practice. That's where the gaps are. Okay, that's where you see you have to leave it at a point so that you can concentrate on the laboratory medicine part. However, when we have such a trainings, there are trainings that can cut across board. Like now, this training, I wish clinicians were there because this is a common training now that can that will require even the gynecologist to be there, or even the pediatricians to be there, physicians to be there, nurses, clinical officers to be there. And I think that's how I can answer it.
Thank you very much, Mr. Agri, for that. And Anthony, thank you as well for enlightening our minds about some of the progresses that we may need to foresee. And we really wish that such can come up and be executed. I think our profession will glitter so much. Now, there's another question. Susan is asking, Susan Murede, is there a test that can be included in the ANC profile to prevent congenital hypothyroidism? Or if I can transform it, Susan might be, would be suggesting that the thyroid hormones can be included in the ANC profile. I don't know. What is your input to that, Mr. Agro?
Okay, there are some cases whereby there is an extended ANC profile, and this goes hand in hand with the clinical history or even the family history of hypothyroidism or the previous clinical history of the mother. Yes, there are times it can be included, especially when the clinical history indicates that it should be done. But clinicians should be very keen, to, especially in taking clinical history. You'll combine, okay, we have at hand an expectant woman who is undergoing ANC profile. It's good for us clinicians to include the thyroid assessment in the course of the antenatal processes. It's very, very important for this to be included. But when there is no clear, because of the resources, we have a poor resource country, and maybe in future when our country is okay, it's a first world country. It will maybe create policies whereby every expectant woman should be screened for thyroid issues. I think when there are enough resources and the patient is able to pay for it, why can't it be a mandatory test for each and every expectant woman? It should be included in the ANC profile. I think there are some things that we need to consider, even if we are a third world country. It's a key issue that should be considered. And I know there are standards, usually some hospitals use, especially in trying to check the safety of the mother and the safety of the child, and the nitty-gritties that usually move in tandem with the safety of both the mother and the child, and the clinical history thereof. Those are very key things that should be considered, and some things should never be should never be overlooked. So it's very important for the clinical history to be considered for the same.
Great, thank you very much. We hope that such can be implemented even before we transform our economy to look like that one for Singapore. That's very important. Now, the last question from Kiprono Brian. Kiprono is asking, why is TSH so high in newborns before it slowly declines to normalcy days after birth? I think you explained this, Mr. Agri,
That's a
but
very good question. Yes.
just give it a touch to allow Kiprono Brian to be able to understand. Over to you, Mr. Agri.
Yes, thanks very much. If I can expound a little bit, just briefly, because I talked about this in the slides, and you can go and watch them and as time goes by. Now, there is what we call a physiological surge of TSH, and this one can be due to stress during delivery. Remember that physiological surge can also occur in acute illness or acute on conditions that usually that are stressful to the mother. And also, not only to the mother, but also to the baby. The baby has been exposed to a cold environment of now, because of the early days of life, from transition from utero to the external environment. It's a stressful environment that also triggers babies to cry. It's a stressful environment, from comfort of 9 months to a stressful external environment. That will trigger a surge in TSH. And this moves in tandem. That's for the next 24 hours, even beyond 24 hours, there will be a surge in this. But now, it brings us into a question, how do we look at this TSH? As I explained, and you revisit the slide, we should look TSH in tandem with also T4, so that we are able to diagnose neonatal hypothyroidism. So that stressful environment, both to the mother and the baby, can cause that elevation. So that's physiological, and it's a normal response. But now the abnormalities occur in the nitty-gritties that I've explained in the slides that I presented, especially for diagnosis, proper diagnosis of the condition that you've talked about.
Great, thank you very much for that. I hope that Mr. Kiprono, you've been able to just grasp some of the reasons why such things happen. You are also free to do some reviews because we've live streamed this session on YouTube, so you can just go and watch it on YouTube and get some integrities. In addition to more research and studies, I think that's very important. Thank you very much. On behalf of LMSK, I would like to say thank you and appreciate everyone for making it to our session today, being the 31st of December 2025, the last day of the year, and we are counting hours to end this year. I would also like to appreciate in absentia those who have not managed to attend today's session because one reason or the other, being a festive season and maybe attaining the minimum points required, the 50 points that are required by the regulator. Kindly accept our deep and sincere appreciation for being part and parcel of us, part and parcel of our growth, and part and parcel of our developments as much, as far as CPT provision is concerned. And with that, I wish each and everyone a happy new year and a prosperous one, even as we come to a close of this session. So before we close this session, allow me to just give a chance to our presenter just to give us a parting shot for concluding this session and maybe also for concluding this year. I think that's equally in order. So over to you, Mr. Agri. Just a parting shot from you.
Thanks a lot, Mr. George. Thank you. Really appreciate LMSK for. It's a great honor that you have allowed me to close the presentations for this year. And as we celebrate the end of the year 2025, we celebrate it, but we know that it's best way to new beginnings. I wish every one of you most beautiful beginnings, and of course, if you want a beautiful ending 2026, you can design it by being proactive in your resolutions. Happy holidays and happy new year 2026 tomorrow. To LMSK, to you, George, really appreciate. To LMSK and to the entire lab fraternity, be blessed and have a happy new year 2026 tomorrow.
Thank you very much for your warm wishes and also the appreciations to LMSK and myself personally. We equally appreciate your presence, your dedication, and your time that you have taken to design your presentations, do your research, and envelope a wide and well thought pieces of work to form part and parcel of your presentations so that we can absorb clearly what we need to get. And indeed, even today's session has reflected your dedication that you put forward to ensure that medical laboratory practice is enhanced. So thank you very much for that. On behalf of MSK, we really appreciate your involvement and other speakers who've managed to present on our platform in absentia. We really appreciate you, and may the next year, 2026, be great for you as well. To our members, we say thank you, and may the next year be more prosperous for you in your areas of work. Those who have not got maybe a place to work, may next year be your year. And with that, allow me to bring this session to a close. And on behalf of LMSK, we wish you the very best as you cross over to the next year. We are here for you, and we will still be offering all the support that you need to ensure that the laboratory, the medical laboratory practice is to the standards that it should be. Thank you very much, and may this evening be a blessed one to you as you cross over. Thank you very much, everyone. Goodbye.